Hola a todos, buenas tardes, buenas noches ya en algunas latitudes. Sean bienvenidos al webinar de hoy. Soy el doctor Oscar Olvera, gerente médico del laboratorio de Sofía, y es un gusto poder dirigirme nuevamente a ustedes y tener la oportunidad de saludarlos. Les agradezco el espacio que hacen en sus agendas para poder acompañarnos el día de hoy, ya que dentro de esta nueva normalidad hay quienes ya están regresando poco a poco a laborar. Y tocando el tema de la nueva normalidad, quisiera compartir con ustedes el mensaje que desde junio viene utilizando la UNESCO en su campaña La Nueva Normalidad. Si tienen la oportunidad de entrar a su sitio y revisarlo, creo que vale la pena que lo revisen. El mensaje al final es claro. Ahora es el momento de construir algo mejor que lo normal. Todo empieza con la educación, la ciencia, la cultura y la información. Este es un mensaje que la UNESCO ha estado transmitiendo desde junio. Como laboratorio Sofía, queremos continuar abonando dentro de nuestras capacidades a la educación médica continua, a la profundización de la ciencia desde la investigación responsable y a ser facilitadores de información. El webinar de hoy lleva por título Enfermedad de la superficie ocular y glaucoma y más allá. El mes pasado, dentro del marco del Congreso Colombiano, el doctor Asrani presentó esta ponencia, la cual traemos con mucho gusto el día de hoy para todos ustedes. Le doy la bienvenida a nuestro ponente del día de hoy, el doctor Asrani, quien es especialista en glaucoma y en cirugía de catarata. Es un apasionado investigador, ha recibido múltiples galardones y grants, así como ha sido autor de varias publicaciones científicas con un área de interés específico en el desarrollo de implantes y la utilización de nuevas tecnologías para detección temprana de glaucoma. Es además miembro del profesorado de la Universidad de Duke y parte del cuerpo médico y docente del Duke Eye Center. Dr. Asrani, I'm glad that you're joining us this evening. As usual, it's great to say hi. It's an honor to be with you this evening and be able to share with our attendees your lecture.
Thank you, Oscar. It's a pleasure, and I thank you and Sophia Laboratories for allowing me to present some of my work on glaucoma, ocular surface disease, and beyond. We are going to be talking about some sort of a torture that goes on in the glaucoma clinic. We glaucoma specialists, we cause dry eye. We also worsen dry eye, and we try to treat it, leading to a vicious cycle of worsening glaucoma, eye discomfort, and poor vision. The common scenario in the glaucoma clinic is as follows. The patient gets started typically because of high pressure on prostaglandins, which causes irritation, chalasia formation, therefore poor compliance and poor pressure control. And then they get a second drop, for example, brimonidine, which causes redness, itching, and watering because of a typical allergic response. And then to treat the allergic response, they get a mild steroid added, which results in higher pressure, which results in more eye drops like dorzolamide, and so on and so forth. And this cycle goes on. Now, we usually tend to use the word ocular surface disease and not dry eye. And I'll explain to you why not in a little while. Ocular surface disease includes any condition that leads to a dysfunctional tear film that causes noticeable irritation to the eye and worsening of vision. It is related to both structural or functional problems of the eyelids, conjunctiva or cornea. And the two commonest forms are blepharitis, which is inflammation of the eyelids like meibomian gland dysfunction, or low production of tears like Sjogren's syndrome. As you can see in the picture here on this slide, there is a lot of staining on the cornea just at the junction of the upper 2/3 and the lower 1/3. This typical staining will be seen in cases where there is posterior blepharitis, that is meibomian gland disease, or lag ophthalmos and evaporative dry eye. One of the two can easily cause this typical symptom and sign. The reason we do not call it dry eye is because patients do not experience dry eye. Patients have different symptoms, such as watering. And when they have watering, and you make a diagnosis of dry eye, it is contradictory to the patient. Ocular surface disease is directly related to the management of glaucoma. It also helps with the diagnosis and in the management of glaucoma. How? Because it leads to a visit to the glaucoma specialist because the eye pain. Because of the eye pain, there is fear. The pressure gets checked and glaucoma gets diagnosed. Then, because of ocular surface disease symptoms, because of eye pain or fluctuating vision, the patient gets worried about eye pressure, especially if they have not been using eye drops. And then they return for a follow-up to make sure their pressure is okay. So ocular surface disease and glaucoma work hand in hand. It is directly related to the management of glaucoma. It causes noticeable irritation to the glaucoma specialist. It is the patient's problem. Remember that glaucoma is the doctor's problem. If we don't address ocular surface disease, which is the patient's problem, the patient does not get relief of the symptoms with which the patient presented and is thus not happy with the doctor, and then will write a bad review. It is the disconnect between the patient and the glaucoma specialist. We, as glaucoma specialists, will pay attention to intraocular pressure, visual fields, OCT, cataract, etc., while the patient is focused primarily on eye comfort and central acuity. We call it dry eye, but the patient experiences epiphora and then will feel the need to go to another eye doctor because he feels that this doctor doesn't know what he's talking about because my eyes are watering all the time. So I tend to explain to the patient that the tears are not sticking to the eyeball and therefore they're falling down on the cheek, and that's why you are experiencing watering. If you had sticky, nice, healthy tears or artificial tears that are sticky, then the eye gets coated and therefore will not result in watering because the eye surface is coated. The symptoms that are classic of dry eye are aching pain behind the eyeball. This is a very classic symptom. They complain like as if they have a toothache behind the eye. They sometimes will complain of forehead headache or ocular fatigue with eyelid heaviness, fluctuating visual acuity, of course, the standard symptoms of watering, burning, foreign body sensation, and photophobia. Now, the risk factors for ocular surface disease include many things like the toxic preservative load, that is preserved artificial tears or multiple glaucoma drops, or sometimes contact lens overwear, or sometimes it could be just the environment where there is heat in the home and in the office in winter. So just like the nose gets dry, the eyes also get dry. And the most frequent cause of dry eye is Apple, Samsung, and Dell because of all the screens that we are using all the time, just like the one you're using right now. So we tend not to blink when we use the screen. Our blink rate is 3 times a minute. When we are using a screen, the blink rate drops to once in 3 minutes. So it is an exhausting exercise for the patient's eye to look at a screen. Other causes of ocular surface disease can include Sjogren's syndrome, that is inadequate quantity of tears, and then the poor quality of tears resulting in an unstable tear film is rosacea-induced blepharitis, which gets worsened by prostaglandins. Trichiasis gets worsened due to eyelash growth, and allergic reactions to eye drops and preservative toxicity. There is one more that I haven't mentioned on this slide, and that is oral anticholinergic load. A lot of patients are on antidepressants and anti-anxiety medications, as well as anti-allergy medications. All of these have an anticholinergic component to it, which worsens dry eye. So what you'll notice is that despite everything you do to the eye, sometimes it is the systemic medications that also need to be addressed. Now, the number of medications is directly proportional to the patients with dry eye syndrome. As you can see in this study, The greater the number of medications, the greater the number of patients with dry eye syndrome, or they should have used the word ocular surface disease and not dry eye. The pressure lowering medications, the long-term administration of glaucoma drops has been linked to ocular surface changes. And these changes induced by preservatives lead to poor tolerance of eye drops. This leads to entire panel discussions, conferences, papers, and research on adherence and compliance of glaucoma medications, which is something we are causing by giving patients multiple eye drops. It is also sometimes leads to new drugs to get the red out that is now recently being sold in the United States as a drug that is called Lumify. It is available over the counter to get the red out. But that's all because of all the toxic preservatives load. Sometimes surface disease is caused after glaucoma surgery. For example, in this right eye here, there is a lid retraction due to a bleb. Not only is there poor cosmesis and lag of thalamus, but also bleb dysesthesia because an air bubble gets trapped right here between the eyelid and the bleb. And every time the patient blinks, the air bubble explodes, resulting in constant discomfort. Ocular surface disease can also be caused by eyelids. We teach our patients how to instill their eye drops, but in fact, that method is exactly the way we tell our patients how to give yourself an ectropion. You can see by chronic installation of drops, the eyelids get pulled downwards. Then when the eye waters, they wipe downwards. And this results in continuous watering and drop washout. So we tend to tell our patients, please wipe upwards towards the upper lid, not downwards on the cheek. There are typical allergic reactions to glaucoma medications, which can be misdiagnosed as dry eye. For example, brimonidine will cause multiple follicles and significant redness. This appearance of contact dermatitis on the eyelids is typical of a topical carbonic anhydrase inhibitor. And this reaction, where rosacea blepharitis gets worsened, is due to prostaglandins. Now, let's talk about preservatives. In 1972, the US FDA said all preparations for ophthalmic use must be sterile. All preparations packed in multi-dose containers, that means bottles, must contain one or more suitable and harmless substances that will inhibit the growth of microorganisms. How do the preservatives work? They interfere with the microbial organisms by causing increase of membrane permeability, lysis of the cell membrane, and loss of cytoplasmic material, resulting in cell death. There are two classes of preservatives: detergent, which is BAK or benzalkylonium chloride or polyquad, and oxidizing purite, Gen Aqua or Softseal. But I want you to realize one thing, and that is these detergent or oxidizing chemicals cannot differentiate between microbial organisms and healthy conjunctival cells or corneal cells. So this toxic reaction that is happening on microbial organisms is also happening on the ocular surface. Now, benzalkylonium chloride actually reduces tear production as well. Here is a study in which normal basal tear turnover was 15% per minute. The moment they put a beta blocker with a preservative, it dropped by 50%. That is, it became 10. Beta blockers themselves, without preservatives, also do reduce the tear turnover rate. But along with the preservatives, it's almost 50% less. Half-life of BAK in the ocular surface tissue In an in vivo rabbit study, benzalkylonium chloride was found in the ocular surface tissues up to 168 hours after a single 30 microliter drop of 0.01% BAK. In the corneal epithelium, the half-life was 20 hours, conjunctiva 11 hours, and the corneal stroma 8 hours. This is a very long half-life for a drug that is supposed to only inactivate microorganisms in the bottle. This is what happens to the corneal epithelium after benzalkylonium chloride. There is a loss of glycocalyx on top here, and the mucin goes down. This results in loss of cellular adhesion, and this results in epithelial permeability. And you know this, you take a glaucoma patient and put a drop of fluorescein. If they are on multiple medications, you will see the fluorescein flare in the anterior chamber within a few minutes. That's because their ocular surface is hyperpermeable because of preservatives that they have been using in their ocular medications. This is a slide that you may have seen previously, where they did a conjunctival substantia propria biopsy in two groups. The primary treatment group, where the patients underwent glaucoma surgery right away, or who were treated for many years with eye drops. And they found that those eyes that had been treated for many years with eye drops had a lot of macrophages, lymphocytes, and fibroblasts. BAK containing medications have even entered human lens epithelial cells in vitro. And in vitro, it has been shown to enter cells in the trabeculum. Now, if the BAK enters the anterior chamber, which it does, because it is present in the corneal stroma also, is it possible that it may have toxicity to the corneal endothelium, to maybe the trabecular meshwork cells? And so, using preserved glaucoma drops, are we causing glaucomas to continue getting worse by slowly degrading the trabecular meshwork cells? We don't know yet. What the studies will show once many years of preservative-free glaucoma drops have been available. Now, reducing the ocular surface effects of glaucoma treatment, we need to use preservative-free glaucoma drops. We also need to use combination drop therapy because it results in half the preservative load. Instead of putting 2 drops with preservative, you put 1 drop with preservative. That is half the preservative load. Or sometimes just use monotherapy, like a prostaglandin, and combine it with SLT laser. One must educate about lid hygiene, encourage preservative-free artificial tears, or offer punctal plugs if tear quantity is a problem. Consider glaucoma surgery when the toxicity worsens the vision, or the patient is not able to tolerate the glaucoma drops. We are now going to switch gears. We are going to talk about what is the target pressure for glaucoma that I typically set. Now, I don't set a target number, but a target range. And these are based on the Canadian Society guidelines and my personal choice after mental note of pachymetry. So in the advanced glaucoma, the target range is low teens with least fluctuation tolerance from visit to visit. Should be less than 3 millimeters. Moderate glaucoma, mid-teens, less than 4 fluctuation. Mild glaucoma, high teens with fluctuation less than 5. What do I mean by mental note of pachymetry? That means if the corneal thickness is in the low 500s or 400s, then I have to ratchet down 1 degree lower. Whereas if the pachymetry is in the high 500s or 600s, maybe I have to ratchet it upwards. The reason for the choices that I made and showed you in the previous slide is this. This is a study that we published in the year 2000, where we showed that the relative risk of disease progression in 5 years for an eye that has a range of pressure of 5.4 millimeters of mercury is almost 6 times higher than an eye that has a range of 3 millimeters of mercury. That means if an eye is fluctuating between 15 and 18, it's not going to progress very fast. Whereas if the eye is fluctuating between 18 and 12 millimeters of mercury, it has a 6 times higher chance of progressing. Additional therapy. Approximately 30% of our patients starting treatment typically require additional treatment within 1 year of starting the first eye drop. If and when it is combined with the prostaglandin, that is the additional treatment, all patients are using drops twice a day, morning and evening. Many patients receive a fixed combination product as an initial treatment after prostaglandin. There is a prescribing trend towards earlier, more aggressive medical treatment to control the pressure better. And why is that? Because it may improve treatment adherence, therefore might improve stability of pressure control over time. That is why a lot of us are prescribing fixed combination products rather than individual eye drops after we have started prostaglandin. What is the other reason for adding fixed combination? You get greater pressure lowering and there is more confidence in the treating physician. So if the pressure came down from 25 to 15 on an eye drop that you added, the patient feels very confident in the physician's capabilities. It gives a positive reinforcement also for the patient to comply with the eye drop because he knows that the eye drop is not only working, but working significantly. It results in fewer visit costs because now that the pressure has come down significantly, you're not as worried. Also, you're not adding eye drops incrementally, especially of course if there are no allergic reactions. It also gives you a more consistent lowering of the pressure throughout the day because you've got eye drops that work with 2 or 3 different mechanisms. So you get a much less fluctuation and therefore better stability of glaucoma. Let's look at an example of comparison of latanoprost to dorzolamide timolol combination. This is a study published in 2002, which was a meta-analysis of 5 studies that looked at latanoprost and dorzolamide timolol. They found that the pressure reduction, 4.5 and 4.2, were very similar. So they say, when used in combination, a prostaglandin, which is an outflow enhancer, an aqueous suppressant, which is dorzolamide timolol, which is an inflow suppressor, offer complementary mechanisms of action. Many people even call this maximum tolerated medical therapy because it results in 2 bottles. And this is something 80% of our patients are able to comply with. When you start using a 3rd bottle, the compliance goes down dramatically. This is a study that showed that in 24-hour baseline pressures, and then after using dorzolamide timolol in week 8. So the range before was 4.7, the range after was 2.5. So not only did the mean pressure go down, but the range also dropped. Other reasons for adding fixed combination? Of course, as I mentioned, there is reduced exposure to preservatives or sometimes no preservatives. It reduces the washout effects. Very, very few patients are waiting 5 minutes between the drops. If they wait 5 minutes, many times they forget to use the second eye drop because they get busy with life. So washout effect is very important. Reduces the total number of times somebody has to remember to do eye drops. And it's still twice a day dosing like single agents when combined with prostaglandin. So conclusion and future directions. The consideration in choice of glaucoma medications should be side effects, compliance and adherence, cost, effects on IOP fluctuation, and quality of life. One must keep in mind you're treating a disease, the glaucoma, which has no symptoms typically for the patient. And when we start treatment, we are actually causing symptoms. So we have to do our best to keep the irritation and the symptoms from getting worse so that the patient doesn't find it useful to take the drops. We must understand side effects and allergic reactions to various glaucoma medications and increase the use of artificial tears if the patient has increased screen time, which is nowadays, like during COVID. Ocular surface disease is very common amongst glaucoma patients, and symptoms are a major source of non-compliance. Reducing DAK exposure is in the best interest of the patient to preserve the tissue in case surgery is needed in the future. Thank you very much for your attention.
Thank you, Doctor, for a great presentation. And now we'll move on to the Q&A section. So we do have a few questions. One question is, a patient with ocular hypertension, no glaucoma, what range of IOP fluctuation would you consider to be safe?
So if there is no evidence of glaucomatous damage, but only ocular hypertension, which is not comfortable for the patient's doctor to watch, then I would want the fluctuation to be less than 5 millimeters of mercury. So you say, for example, if the pressure is fluctuating between 20 and 28, that's not acceptable. It has to be less. It has to come down between 21 and 25 or 20 and 25 at the most. And typically, even if there is ocular hypertension, we don't want the pressures to cross the mid-20s. That is our typical threshold that most of the glaucoma specialists utilize. Of course, with normal tachymetry.
Thank you, Doctor. Another question is, for many of us that work mostly in public health institutions, the time is most of the times a limitation. What tests or questions do you believe are the more important to perform to evaluate the ocular surface in our glaucoma patients?
Yes, the person who's asking the question is absolutely practical and correct. We do not have much time. So some of the best questions to ask the patient are, how do your eyes feel? How is your comfort? Are you comfortable? Do your eyes have, you do not have to ask leading questions. You can just ask if the eyes are comfortable. And if they say they are having discomfort, then you have to ask, what is the symptom? Is it watering? Is it burning? Is it a foreign body sensation? Is it the change in vision that happens many times in a day, that blinking improves it? Or is it just redness and irritation and watering? And you can look at the eye examination very quickly to identify what's the cause. If the meibomian glands are congested, inflamed, then typically posterior blepharitis, and that can be easily treated with lid hygiene and other mechanisms of treatment for blepharitis.
Okay, thank you, Doctor. I believe this question is in relation with the previous one, and they are asking if you believe that all of our glaucoma patients should go to a full or thorough ocular surface disease evaluation. And I mean, the previous question is, we have limited time, right, to do this evaluation because we are treating glaucoma. So
yes.
Do you believe that all of glaucoma patients should have a specialty consultation for ocular surface disease, or we should choose our patients to this evaluation?
We should choose, because we don't have time, nor does the patient have time. So if the patient doesn't complain, that is, if the patient is fine, is having no complaints, vision is stable, eye has no watering, patient is compliant, and how we assess compliance is by asking the following question. How many times in a month do you miss your drops? 3 days a month, 5 days a month, or 7 days a month? And if they say 7, that means they are not even using it half the month. If they say 5, they're missing it 7 days a month. If they are saying 3, they're missing it 5. If they say I'm missing none, that means they're missing 2 to 3 days a month. So that's how we assess compliance. And if the patient is compliant, has got no symptoms, there is no need to further investigate the ocular surface disease. Provided, of course, the conjunctiva and eyelids also look healthy. So I try to spend an equal amount of time for the patient's disease, which is the ocular surface disease, and then what I call my disease, the disease I treat, which is glaucoma. I first always address the patient's problems, and then I say, okay, now let's shift over to something I am interested as well.
Okay, thank you. So, leaving the preservatives aside, thinking about the ocular surface disease, what drug do you believe is the safest to use in a patient with ocular surface disease with a lot of symptoms? Do you choose the prostaglandins analogs or the beta blockers, or what is your choice in regards of the active principle?
So if somebody has severe ocular surface disease, the best drug is no drug. It is only going to worsen whatever you add on there. But if you have to, because the patient is either not a candidate for laser or surgery for glaucoma because it's too early or they are very hesitant, then I would look at the ocular surface and then decide. If the patient has severe posterior blepharitis, I would not start with a prostaglandin because that will only worsen it. I would start with a combination agent, which would give me the same amount of pressure control as the prostaglandin, but not worsen the posterior blepharitis. It also depends on the allergic reactions. Some patients develop allergic reactions, and you have to find out which one the eye is allergic to. So based on the findings, I would choose. Now, for example, dorzolamide burns, but that's because of the pH of the drug, and it's got nothing to do with the dryness. So that doesn't mean that brimonidine, which doesn't burn, doesn't cause any dryness. It is also causing the same amount.
Okay, thank you. How can we evaluate the impact in quality of life from switching from a preservative-free drug to from a preservative-containing drug?
Sometimes it is not evident in the quality of life if you switch from preservative to preservative-free. Many times the patient will say, oh, I didn't experience any improvement, any benefit. But you have to ask yourself, if you were the patient, what kind of drop would you use? Would you use one that is preservative-free? Of course, I would use one that is preservative-free because I do not want to mess up my ocular surface. in case I need surgery later. I do not want to mess up the possibility of the trabecular meshwork cells being slowly getting damaged by the preservative. I would rather use just the drug without the preservatives if it is available. So it may not improve necessarily the quality of life. If it does, fantastic. But 8 out of 10 times the patient says, nah, it didn't make much difference. But I explain to them that this is the kind of drug I would use on my eye. And that's why I'm recommending that.
Okay, thank you. Mm-hmm. So another question is, in a patient with ocular surface surgery or cataract surgery and glaucoma, what is the best treatment if the patient is complaining about ocular surface symptoms?
The one thing to do is to try and consolidate the glaucoma drops before you start the cataract surgery. That is, reduce the number of drops by combining it with SLT laser. So do SLT laser and drops. So you can reduce the number of drops that are going in. You also want to optimize the ocular surface before you embark on cataract surgery. So one thing I do is typically I do not use prostaglandins after cataract surgery for about 6 to 8 weeks. I will typically use brimonidine after cataract surgery. And the reason is that the chances of the eye developing an allergic reaction to brimonidine are negligible in the post-operative period because the patient is using prednisolone, the steroid drops. So if the steroid drops are going in, they do not develop an allergic reaction to any of the drops. So brimonidine is very soothing to the eye, at least in comfort-wise. So therefore, I tend to prefer combination of brimonidine and a beta blocker. If I have to, I will use all three, that is, in combination or separately, preferably in combination because the patient is already using steroids and non-steroidal and antibiotic and things like that. Of course, there are some sustained drug delivery techniques that are coming out that probably will be helping us in the ocular surface disease treatment in the future.
Okay, thank you. So have you noticed any difference between generations? I mean, between the baby boomers, the Generation X, and now the millennials in regards of the adherence or compliance to the glaucoma treatment? Or do you believe any generation it's equal in this regard?
I think it's not the generation, but it is the age of the patient. If the patient has in his mid-40s and 50s, they are aspiring for a career and taking care of a family and holding on to their job. And they've got so many commitments that to tell them to do multiple glaucoma drops is impractical. They'll fall asleep trying to put their children to sleep and then forget to use their eye drops. Then the patients, and also they, at the younger age, up to the age of 45, 50, all patients feel invincible. They feel nothing will happen to them. At around 45, 50, when presbyopia hits, is when they realize they are not invincible. And that's when the compliance improves. And when they're retired in their 70s and 80s, they are desperately trying to hold on for their vision because they know that as they age, their joints are not going to work, their hearing is going down, and they can't do a lot of outdoor activities, but they can read. So they are very desperate to keep their vision, and they realize that, and therefore their compliance increases tremendously. It is surprising, after COVID has hit, the majority of my patients coming to my clinic are above 80. Despite them being in the highest risk category, but they are the ones who are most afraid of losing their vision. So I don't think it is the generation, I think it is just a function of age.
Okay, thank you, doctor. So in regards of treating the ocular surface disease, do you have a place in your treatment for cyclosporine or steroids like fluoromethalone?
I am extremely hesitant to use a steroid, even if it is a mild steroid, because I don't know which patient is going to be super sensitive to the pressure effects of the steroid. And therefore, I am very liberal with cyclosporine drugs or lubricant drugs like artificial tears that are viscous. If viscous artificial tears are available and they coat the surface, then I tend to go with that. If not, then I will offer the patient cyclosporine drugs. But I have not seen a universal response to cyclosporine. And therefore, I tend to offer patients plugs for the tear ducts first, after the use of artificial tears, before I go to cyclosporine.
Okay, thank you. So do you use the SLT in your glaucoma treatment algorithm?
Very frequently, very frequently. There are patients who have very severe ocular surface disease who will not tolerate any of the drops that you put in. Those are the ones, they are the first candidates for SLT. The younger patients, under 45, like I explained, if they need 2 kinds of eye drops, or they need drops more than once a day, then I will do a combination of prostaglandin and SLT.
Okay, thank you. Let me see if there is another question that we haven't asked already. So, do you believe there is still a place for preservatives in glaucoma medications?
Absolutely. If somebody is 75, 80 years of age, they got mild glaucoma, and they're doing once a day prostaglandin, what's the harm? What's the harm in them taking a 1 drop of preservative in the, once a day? It's when you're using multiple drops, or the patient already has severe dry eye, and on top of that, you're trying to add new drops. It's like adding fuel to the fire. So I'm not opposed to having preservatives or using drops with them, but you have to use it judiciously.
Okay, thank you. Do you use in your very severe dry eye patients, do you use autologous serum?
Yes, I do not personally use that, but when the patient has severe dry eye, at that stage I refer them to a ocular surface specialist who deals with dry eye, and those are commonly prescribing autologous serum. So
we don't have much experience here in Latin America with the rockiness inhibitors like netarsudil. So what's your experience with these drugs, and what's the impact on the ocular surface?
So there are 2 impacts on the ocular surface. One is the standard impact because it has the typical standard preservatives. The other impact is the cosmetic appearance of redness. The redness that is there, the hyperemia, that is sometimes there in about 20% of the patients who are using this eye drop, sometimes is not tolerable by the patient. But many times the patient can tolerate the hyperemia. This is a great addition to when patients cannot take a beta blocker because they have asthma or emphysema or contraindicated. Sometimes there is nothing left. The beta blocker cannot be used, or they are allergic to brimonidine, or they can't tolerate dorzolamide. Then a great addition to the prostaglandin is the Rho kinase inhibitor.
Okay. In your own practice, what percentage of patients, of glaucoma patients, are under treatment with artificial tears or lubricants?
I would estimate about 80%.
Okay.
Because most of my patients are quite old also. And they're also on many anticholinergic drugs orally. So they have dry eye. They also happen to have glaucoma.
So I believe this question is linked to a previous one, but it's a recurrent question. So taking in consideration these symptoms and signs dissociations that exist in the ocular surface disease, how do you manage the patients that are getting a benefit from preservative-free medications in regard of their signs, but not so much symptom-wise?
That is a tough question. Many times I will ask them to withhold the glaucoma drop for 4 or 5 days in one eye to see if the symptoms improve. Say they are already taking preservative-free prostaglandin in both eyes, and it is causing them discomfort, pain, irritation, and so forth. It's already preservative-free. What you can do is try for 4 or 5 days, just stop the prostaglandin in one eye and see, ask the patient at the end of the 5 days, ask yourself and tell me whether there is a difference in the symptom. If the eye felt tremendously better in the eye that you stopped the medication, then yes, your eye drop is contributing to it. But if the eye doesn't feel better at all, it's the same, then you know that it's an underlying dry eye that you have to manage and treat with maybe autologous serum, maybe cyclosporin, maybe plugs, maybe extra thick artificial tears.
Okay, thank you. So a final one, what do you foresee or think is the future in regards of the topical treatment for glaucoma?
I think topical treatment will always have a role to play in glaucoma because it is a form of therapy that can be stopped and started at the doctor's or the patient's will, whereas sustained drug delivery and treatment cannot easily be turned off and turned on when required. So, though in the future, sustained drug delivery will be there and play a role, but eye drops will also play a role. Until we get to a point where we got a sustained drug delivery that we can turn on and off.
Okay, thank you, doctor. Well, doctor, once again, I'm extremely obliged to you for your time, for the lecture. I'm sure these concepts will help us deliver better care to our patients. There were a lot of take-home points that should be of great use. And also to continue to raise awareness about the importance of the OSD prevalence and its adverse effects in our patients. It's of great help. So thank you very much, doctor, for your time for this lecture.
My pleasure, and all the best to everyone, and stay safe. Thank you.
Thank you, doctor. Muchas gracias a todos por su atención y preferencia. Continúen cuidándose mucho y nos estamos viendo.